dengan UNICEF selama ini. Keterlibatan atau partisipasi tentu merasa bertanggung jawab dengan kegiatan yang nantinya akan memberikan manfaat yang besar bagi masyarakat khususnya di Sulawesi. Kegiatan ini sebenarnya merupakan kegiatan kedua yang telah diselenggarakan dalam fokus preventif wasting ini. Kegiatan pertama itu ada webinar series. Yang pertama yang bertema Ayo Cegah dan Obati Wasting Biar Tidak Stunting. Hadirin yang berbahagia, kita ketahui masalah gizi buruk dan gizi kurang atau yang kita sebut wasting ini merupakan tantangan kesehatan global yang mempengaruhi jutaan orang di seluruh dunia, terutama di negara berkembang. Di tingkat global, upaya untuk penurunan prevalensi gizi buruk dan gizi kurang telah ditetapkan dengan target turun hingga 5% pada tahun 2025 dan 3% pada tahun 2030. Secara nasional, Indonesia juga telah menetapkan target prevalensi gizi buruk dan gizi kurang ini sebesar 7% pada tahun 2024. Ya, tahun ini. Sesuai dengan RPJMN 2020-2024. Namun kita lihat data terbaru bahwa prevalensi gizi buruk dan gizi kurang di Indonesia mengalami peningkatan. Kalau kita lihat data 3 tahun terakhir dari 2021, 7,1%, gabungan antara gizi buruk dan gizi kurang, 2022 7,1, data S.G, kemudian 2023 kalau kita lihat data SKI naik menjadi 8,5%. Begitu juga yang ada di Sulsel, justru terjadi peningkatan. Dan kita tahu bahwa penyebab masalah gizi ini sangat kompleks. Ya, kita kenal ada penyebab langsung, penyebab tidak langsung, dan akar masalah. Dalam rangka mengatasi tantangan ini, serangkaian webinar dan kuliah umum tentang masalah gizi ini dilakukan untuk meningkatkan pengetahuan, kesadaran, dan agar pemahaman kita lebih baik tentang penyebab dampak kondisi tersebut, serta bagaimana mempromosikan strategi pencegahan dan penanganan yang efektif. Tentu diharapkan dari kuliah umum ini akan tercipta kolaborasi yang lebih kuat dalam upaya mengatasi masalah gizi buruk dan gizi kurang, serta meningkatkan kesejahteraan kesehatan masyarakat secara keseluruhan. Untuk itu kami atas nama dari ICONS mengucapkan terima kasih kepada semua peserta yang hadir dan khususnya narasumber dari UNICEF yang mau membagi ilmunya pada kuliah umum hari ini. Semoga kuliah umum ini bisa menambah pengetahuan dan pemahaman kita semua menjadi lebih baik. Tetapi tidak hanya itu, semoga kita bisa segera menindaklanjuti di lapangan sebagai orang-orang yang bertanggung jawab. Terima kasih kepada panitia yang telah bekerja dengan baik dalam penyelenggaraan kuliah umum ini. Sekian sambutan dari saya. Assalamualaikum warahmatullahi wabarakatuh.
Thank you to Professor Dr. Nur Haidar Jafaro for the speech. Next, let us hear a speech from Vice Dean of the Faculty of Public Health Hasanuddin University, who will also officially open today's event. To the Honorable Professor Anwar, we invite you to deliver your remarks.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Our honorary guest speaker today, Dr. Ikhtiar. He is almost complete the PhD in Bangkok. Bangkok ya, bukan Bangkok. In Bangkok, but he's from Philippines. That's why at the first time I recognized his English is very good. I think I wonder if he is a Thai. I should trust that. I don't think that Rin is a Thai. That's why Philippine, yeah, for sure, yeah, the English is very good for Philippines. Yeah, okay, thank you for coming. It is really words for us to share your. Yeah, I think it is a good science, a good knowledge for all our students, also for us. Yeah, and for sure with the team. Ibu boleh perkenalkan dirinya. Ya, yes.
Terima kasih Profesor. Selamat siang Bapak Ibu sekalian. Perkenalkan saya Blandina dari UNICEF Jakarta, bertanggung jawab untuk program pencegahan, deteksi dini dan tata laksana anak wasting.
Terima kasih. Ibu boleh tolong silakan.
Ya, saya perkenalkan diri juga. Saya Nike. Sehari-hari bertugas sebagai staf gizi UNICEF untuk kantor UNICEF di Makassar untuk Provinsi Sulawesi Selatan.
Terima kasih. Ya, dan tentu saja di sini kita punya ahli gizi, Profesor Dr. Nur Hedat Jafar. Ya, dia juga selaku tim untuk ketua ICONS ya di Unhas. Ya, alhamdulillah. Yeah, we really thanks to God that our speaker and also friends be here because it is, yeah, I think it is something also quite new for all of us. Yeah, because relate to nutrition, yeah, it is still a big problem in Indonesia. Yeah, we know that Indonesia is contained with so many provinces. Yeah, some province I think is too late or they are too late in growing the nutrition. Yeah, they especially for the children 5 to under 5 years. Yeah, it is our government now have focus on that concern, but the result is still far from the planning. Yeah, that's why I think we really want to have some description. Also, I think effects, and how to overcome this problem, especially in Indonesia, not only in Indonesia actually for this case, or we can also come to South Asia, how to different, what is the difference, the situation for malnutrition between those countries. Yeah, and Indonesia, hopefully that we also have a good data and how they overcome the problem. So maybe some students also have a possibility to have a research related to this. Yeah, all from bachelor, master, and PhD degree. It is open. Yeah, I think we may give our attention and focus. You will have something new, knowledge, and we can apply, or we can go directly to the field to see, to find out the data. All right. Yeah, I think that's all from me. And this time, I would like to open this guest lecture by saying Bismillahirrahmanirrahim, and please give a big applause for our guests. Demikian, mudah-mudahan manfaat. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Professor Anwar. And with this, the event is officially open. And now I will hand over the event to our moderator. She is Marini Amelia to lead the guest lecture. And to Marini Amelia, the floor is yours.
Okay, thank you very much, our beautiful MC. So, Assalamualaikum warahmatullahi wabarakatuh, and good afternoon, everyone. Yeah, I hope everyone is doing right, and thank you very much for coming here, and we are glad to have you all in the middle of this exam week. this week maybe has been a bit hard for you, and then we're glad to gather here to update our knowledge about wasting. Yeah. So as previously mentioned by Professor Nur Haidar Jafar, that in the recent time, the prevalence of wasting has been increased. Although in the past years we have history to reduce the prevalence of wasting, but currently with a lot of things goings on with pandemic, inflation, and then also climate change, the prevalence of wasting is continue to increase. So we have to be careful, we have to be aware, and we have to prevent that kind of problem. So today we will talk about the management, and also how to treat wasting and edema among infants and children under 8 years old, and what is the current guidelines. So with us, we have Mr. Rene Gerard Cruz as our speaker. But before we start, please let me read his CV. So he graduated from College of Science, University of Philippines, and also College of Medicine from the same university. And he did his master in public health from 2012 to 2013 in Hasada International Master for Public Health Program, the Brown School of Public Health and Community Medicine. And he is currently undergo PhD in the same university. So he has a lot of experience in nutrition, malnutrition, and also public health. He's been working with UNICEF since 2013, and he's been put in various positions. So he started as in the UNICEF Philippines country office from November 2013 to November 2015, and then currently he works in UNICEF East Asia and Pacific Regional Office. So I think this is a chance for us to have a lot of sharing experience with Mr. Rene Gerard. So I think all of you have been really excited to see the current recommendations. So without further ado, I will have the floor to Mr. Rene to share about overview, recommendation, and good practice for wasting. Thank you.
Thank you so much. Salamat siyang, everyone. Professor Anwar and Professor Jafar, thank you so much for having me in this wonderful campus in Unhas. And thank you for your time this afternoon. I heard that you were also very busy with your exams, so thank you for your time this afternoon. I'll make sure to make it worth your while. Okay. I thank you so much for inviting me to speak about something that's very close to my heart and that I've been working on for more than 10 years already. It's really about child wasting. Does anyone know what child wasting means? I will try to keep this a bit informal and interactive. Does anyone know what it means? Child wasting.
Wasting.
Ah, enggak mau ah. Tunggu dulu ganti S.Gz.
Okay, so maybe we go to the next slide because that's where we go. Next slide, please. Oops. One slide back. There you go. Okay. So child wasting refers to a child who is too thin for his or her height, for her height. And it is the result of very rapid weight loss or also the failure to gain weight. When does this usually happen? It usually happens when we are sick, right? We notice that we don't want to eat. We lose the appetite, or also during periods of food insecurity. That includes emergencies, and Madam also mentioned climate change, which also will trigger extreme weather events. It's important to note that a moderately or severely wasted child has increased risk for death. But the good thing is treatment is possible. Okay. And we have to also know that wasting is preventable. We have to make sure that the child receives proper diet, proper care, and also good quality services. So it's not just food. It's really about holistic nutrition, diets, services, and practices. And the practices will also include hand washing. Even if it's after COVID, we still have to remember to wash our hands. Also, immunization coverage is important because if we have low immunization coverage, then the vaccine preventable diseases will also come back. So all of these will influence the risk for child developing wasting. Next, please. So let's look at what it means globally. So globally, wasting threatens the lives of an estimated 45 million children across the world under age of 5 years, of which 13.6 million were suffering from severe wasting. So severe wasting is the severe form, and children with severe wasting have 9 to 12 times increased risk of death compared to a normal child. More than 3/4 of the children with severe wasting live in Asia, and more than half, and another 22%, live in Africa. Before we forget, we also have to note that some children suffer from one form of malnutrition, such as stunting and overweight, or stunting and wasting. And these can coexist in the same child, in the same household, in communities, or even in countries. Next, please. Okay. So what does it mean in the East Asia and Pacific region? So there is a high unfinished agenda for child wasting, with wasting above the threshold of public health significance of greater than 5% in most East Asia and Pacific regional countries, including those with the higher GDP, that includes Thailand and Malaysia. To the far right, we see the topmost, which is PNG. They have currently 14.1% child wasting. Next in line is, can you see? Indonesia. But I have to note that this is an old figure. I know that you have an updated figure in 2023. So this figure is around 10.2. From what I remember, it's around 8.8% in 2023. So, but globally, this is still what we use because that was compiled last year. So we still have a lot to go within the region. And overall, you'll see in the middle, the middle red line, that's the overall wasting prevalence for East Asia and Pacific, which is 3.7%. Next, please. And we have to also remember that wasting prevalence is important, but we also have to remember that this percentage is actually equivalent to a child's life, no? So we have to remember the numbers of children who are affected by wasting. And nearly 80% of the burden of severe wasting in East Asian Pacific are found in 3 countries. And topping the list again is Indonesia. Around half, or 49%, of the burden within the region is found in Indonesia because of the severe number of population. Next, please. Top 2 is also Philippines, so we're also top 3 within the top 3. So Philippines is a part of that list. Okay, also very important graph. We have to remember and break it down by age groups also. So within the under 5 age groups, we look at wasting prevalence across the ages from 0 months up to 23 months and 59 months also. So we have, what do you see here? That most of the children within the first 2 years of life actually are more affected by wasting. So many children in East Asia and Pacific are deprived of their right to good nutrition during the first 1,000 days. Do you know this concept? The first 1,000 days? It's actually comprised of pregnancy. So from conception until birth, so 9 months. How many days is that? Little math. 9 months, how many days? 9 times 30. 9 months, 24 days? No. How many days? Days. 9 months times 30 days is 270. Thank you. So 270, remember that. Then we extend to the first, from birth to first 6 months. So 6 months times 30. 6 times 30, 180. And then the remaining period from 6 months until the 23rd month, which is under 2 years, comprises 550. And if we add that all together, we actually get a very round, nice figure of 1,000. So from pregnancy until the first 2 years of life of the child, we call that the first 1,000 days, or the golden period of opportunity. Okay, so most of the children within East Asian Pacific actually have, for those who have wasting, most of them are actually concentrated within this period, which is something very unfortunate. Okay. Next, please. Okay.
You just stay here.
Okay. Got it. Thank you so much. Okay. Oops. Sorry. So what the good thing is that we have actually a framework for action. So globally, UNICEF, WHO, WFP all work together to make sure that this doesn't happen and this doesn't worsen globally, especially in countries with high burden, no? And we developed this framework for action called the GAP framework, or the Global Action Plan to Reduce Wasting. And the target is to reduce the prevalence of wasting to less than 5% by the year 2025, and to further reduce the prevalence of wasting to less than 3% by 2030. So we are currently in 2024. Indonesia is still at 8.8%, so we still have a long way to go, but it's possible. That's what's good, no? And in this framework, we see that there are 4 pillars, 4 outcomes that actually comprise the various interventions, or the various targets and strategies that we need to focus to reduce wasting. That includes, for example, improving maternal nutrition, improving primary healthcare services, improving breastfeeding and complementary feeding, and also strengthening health systems. So again, focusing again on the concept of the first 1,000 days, looking at the mother and looking at the child and the services and practice that the child needs for it. Okay, so let's now dive into the guidelines itself. So most of the 2013 recommendations still stand. So there was a WHO 2013 guidelines that was launched, so 10 years ago, more than 10 years ago. And what's important is the new 2023 WHO guidelines builds on the strengths of the 2013 guidelines and includes recommendations and good practice statements informed by the best available evidence for the prevention and management of wasting and nutritional edema. It includes 4 focus areas. including infants less than 6 months of age at risk for poor growth and development, moderate wasting in infants and young children, severe wasting and nutritional edema in infants and young children, and of course, the new section, prevention of wasting and nutritional edema from a health perspective. The guidelines is anchored on 6 guiding principles used by the Guideline Development Group, which served as the foundation of good practice statements and recommendations. So first, a child health approach. We have to put child's health and development at the center to avoid siloed programming. At each health contact, we expect that a child's needs be assessed comprehensively, exclude any services that may in a timely and inclusive manner available. The second is the mother recognizing that every action and extension care to both the mother is
So again, the first is looking not at the child, the mother.
to that of her child, and we must see their value as individuals and also collectively. Third is the multi-sectoral action or health system focus. So health services need to be central, accessible, of good quality, and also utilizing community platforms is key to the success of this health system focused approach. The prevention and management of wasting and or nutritional edema must involve other systems besides health system, such as the food, water and sanitation, and social protection systems. This morning we went to one of the Puskesmas and also the ECD Center in Pushandu. And I was happy to see how this multi-sectoral action was in place and working within Makassar itself. So there was a child who needed support for because the family was a little bit vulnerable and also did not have enough income. So what the health worker team did was to reach out to the social welfare team to make sure that they also receive additional benefits not provided by the health team. So just wonderful, wonderful work there. Third is the access to diverse, nutrient-dense, and locally available foods, which will be integral in the prevention and management of wasting and also recovery from SAM. And this is the most sustainable approach because the child after treatment will come home and we have to make sure that he or she accesses this diverse, nutrient-dense, locally available foods. Local adaptation is also very important, especially in our context within the region. We have to make sure that implementation of the recommendations of WHO should be informed by local context and also country-level adaptation. And that's why I know that for Indonesia, they're also doing a lot of evidence generation, including bottleneck analysis, to make sure that such recommendations are also fed by local evidence. And lastly, gender equity. And I'm also happy to see a lot of women here because gender equity recognizes the burden of women in caring for children and the role power of structures, gender norms, also violence, which can result to wasting if the mother is not able to take care of children. So the ownership of resources and that contribute to children is important and their access to interventions. There. So, oops. What do we need to do? So currently, and for most countries, this is where we are, where most services are scattered and are not offering a comprehensive list of services. And we want to move from here to here, where services are more focused, all strategic, and comprehensively available for all children. So we have to make sure that wherever a child presents, they get all the services they need. And we need to work together to support the services which work around the child and not programs which we try to fit children and their families to. Okay. So let's now dive into the 4 subsections of the WHO guidelines, which provides both recommendations and good practice statements. So WHO and UNICEF are also in the process of developing operational guidance, starting with health workers. Hopefully, this will be released in the next 2 months. Yeah, hopefully that will be available and will be shared with countries as well. Okay, let's start with basics terminology. So wasting in infants and children under 5 years of age is defined as having a weight for height or a weight for length disease score more than 2 standard deviations below the median of the WHO child growth standards, or a mid-upper arm circumference less than 125 millimeters, which can be used as an alternative measure. Acute malnutrition is another term that we have to also contend with. Acute malnutrition is defined, and listen carefully, in children under 5 years of age as having a weight for height or weight for length z-score more than 2 SD below the median of the WHO child growth standards, or having nutritional edema. Again, a MUAC less than 125 millimeters can be used as an alternative measure. So what's the difference between wasting and acute malnutrition? Did you catch it? Do I need to define the terms again? Yes? Yes, okay. So again, listen carefully. Wasting in infants and children under 5 years of age is defined as having a weight for height or weight for length z-score more than 2 standard deviations below the median of the WHO guidelines. WHO child growth standards, or a mid-upper arm circumference or MUAC less than 125 millimeters. That's wasting. Acute malnutrition is defined as having a weight for height or weight for length z-score more than 2 SD below the median of the WHO child growth standards, or having nutritional edema. Again, a MUAC less than 125 millimeters can be used as an alternative measure. So what's the difference? I heard something? Did you catch it? What? There's just 2 words. Nutritional edema. Thank you. So it's essentially the same terminology, but if we add nutritional edema, then that becomes acute malnutrition. Okay? So wasting does not include nutritional edema, but if we add nutritional edema, we have to make sure that we change the term to acute malnutrition. It can be confusing, especially for health workers, no? Because these are very technical terms. And that's why within the UNICEF WHO operational guidelines that we will also release this year, we will still use the typical terms of moderate acute malnutrition and severe acute malnutrition, so as to lessen this confusion. Okay? Now, let's focus on the first subsection of the document, infants less than 6 months of age who are at risk of poor growth and development. So this section focuses on infants at risk of poor growth and development, building on the 2013 guidance that had some but limited guidance on infants under 6 months with SAM. Okay, it's working. So the 2023 guidance expands the recommendations to identify and intervene early for infants who are not growing well or who are at risk of poor growth and development before they meet the criteria for severe acute malnutrition. And children with wasting are a subset of this group. The immediate goal of early detection is that we have any acute or psychological problems identified and prevent these infants from becoming severely wasted. So it really is under early detection and early action. And the criteria are as follows. So the first group of infants at risk is based on sequential measures. That's the top circle. An ideal scenario with a couple of data points or time points to show that the infant is not gaining weight or is losing weight. So this is where families who are sequentially or repeatedly accessing the services. But this is also not the case for many of the families, no? So the second category is based on single measures, and that's what you found below. So that's the first measure, and that's the second. And this is based on a single measure if sequential measures are not available. And these are based on specific anthropometric cutoffs that includes MIOAC, which is less than 110 millimeters for infants 6 weeks to 6 months, to less than 6 months, or weight for age, or weight for length, and the presence of nutritional edema. Infants at risk for due to poor growth outcomes are also defined, and these include those that have preterm birth, who are preterm birth, born preterm, or have low birth weight, or are small for gestational age. And the last category of infants is those who are known with known risk factors for poor growth and development. And that includes here maternal risk factors. So again, coming back to the concept of the first 1,000 days, no? So the mothers who are in poor health and maternal mental health concerns are also now highlighted in the new guidelines. So these criteria are there to identify who is at risk, and it is important that we emphasize that further assessment and judgment are required to identify what type of support or intervention each child will need, depending on the situation. This is also a new update on admission, referral, and transfer, and also exit criteria for infants at risk for poor growth and development. The 2013 guidelines that had admission, referral, transfer, and exit for infants were all only with SAM. So now they expanded the criteria to include those who are at risk for poor growth and development. A new step was also added. That's in-depth assessment to make sure that any decisions made, whether an infant needs inpatient or outpatient care, is made with comprehensive assessment that includes medical, nutritional, psychosocial history of both the mother and the infant. There was also clarification of which medical problems should be managed between outpatient and those that need inpatient care. And lastly, there's also guidance on follow-up for infants at risk until they reach 6 months, with reduced frequency of follow-up over the 6 months depending on the infant's condition, the final assessment, and the referral. It's important to note, and the guidelines emphasize this, that program managers and health workers should determine the frequency of follow-up for these infants depending on their contexts. So again, the guiding principle of local context. We now move on to the last section for this subsection, which is also looking at the importance of breastfeeding. So there's also emphasis on early action and managing the health and nutritional needs of the mother. Again, coming back to that guiding principle, no? Recognizing them as an interdependent pair. And problems with breastfeeding has been recognized as the one of the many causes of an infant less than 6 months becoming at risk of poor growth and development. And the guidelines recommended the conduct of a comprehensive assessment of the mother caregiver infant pair and to follow best practices such as IYCF guidance to manage these challenges. The guidelines also touched on the use of supplemental milk, and the guidance recommends to base any decision in which the infant needs supplemental milks after doing a comprehensive assessment. Note that the recommendation on infants with SAM needing supplemental milk in the hospital still stands. So for an infant at risk for poor growth, we need to do an assessment before we provide a decision whether supplemental milk is given. However, for infants meeting the criteria for severe acute malnutrition, supplemental milk is required in addition to breastfeeding. Thirdly, we also have to assess and support mothers and caregivers, not just physically, but also their mental well-being. And prevention and treatment are intertwined through early identification and action, responsive growth, monitoring, and also attending maternal mental health, and also early child stimulation and development. So that includes even for those who are at risk for poor growth or those that will severe acute malnutrition to have interventions that include psychosocial stimulation and play. We now move on to the second subsection, which is now focusing on infants who are a bit older, those who are aged 6 to 59 months with wasting and or nutritional edema. We first focus on those with severe wasting. So for this particular age group, there is emphasis on triage and also overall health assessment. Again, coming back to the theme of comprehensive assessments. So it's recognized that nutritional status is an important part of the initial assessment to decide appropriate care. We have to make sure that we get this right, because if we know that the children with SAM are identified correctly, then they can also get the right treatment early. So recommendations B2 and B5 set out specific criteria for inpatient admission, outpatient enrollment, and when and what to do in an in-depth assessment. It is the same in-depth assessment described for the under 6 months group, which is also consistent with the WHO guidelines, including IMCI. And recommendations and criteria also include when to transfer children from inpatient to outpatient and exit from outpatient care when they recover. Medical conditions that should be managed in inpatient care are defined as per IMCI definition. And note the underlined terms. Children are only admitted in inpatient care and enrolled into outpatient care and transferred from inpatient to outpatient and exited from treatment. So they had to define these terms in the guidelines because globally the terms that were being used. So that when we, with the help of the 2023 guidelines, there was hope, or there was the aim to standardize these terminology so that there is also no confusion when one country speaks to another or when one expert speaks to another. So the standard terminology was proposed. As in the 2013 guidelines, MIWAC, weight for height, and edema are still criteria used to enroll children into treatment for SAM. And note that weight is used to monitor progress, to calculate RUTF dosage and medications. Children can exit treatment when they are no longer meeting the admission criteria. An in-depth assessment is the additional step to determine where and what children should receive. The last bullet, oh, sorry. I didn't move. So there, those are the terms. So again, specific criteria for inpatient admission, outpatient enrollment, the repetitive use of in-depth assessment for both inpatient and outpatient, the use of transfer from inpatient to outpatient and exit for nutritional treatment. And there's also emphasis on the continuity of care between inpatient and outpatient services. We cannot overemphasize the need for seamless referrals and transfer between these types of services, because sometimes we lose children when they are being transferred also from one service to another. So we have to make sure that a hospital communicates and coordinates well with the Pusyando or the Puskesmas or the primary healthcare system. Okay, so also important for the management of wasting is dehydration, because this will change the manner of the treatment as well. So dehydration assessment is very important, and this will actually determine what type of rehydration solution will be given for dehydration and no shock. So Resomel is the preferred type, or that's the rehydration solution for the management of malnutrition. It's preferred still for children with SAM with dehydration but not with shock. However, because this particular solution is not available everywhere, so the use of low osmolarity ORS can be used if Resomel is not available. So this recommendation actually came for trials showing where there's no harm giving ORS and that there's some cost savings in ORS compared to Resomel. And this is actually more generally available. There's not enough evidence to use or recommend hydrolyzed formulas for intolerance to F75 or F100. These are the therapeutic milks for the treatment of severe acute malnutrition at the inpatient level. And also, they recalculated the quantity of RUTF for the duration of the treatment. And there are options now to further reduce the quantity once the child is no longer SAM, considering that this may have actually cost-saving implications. So it was actually, data has actually shown that the reduced dosage did not do any harm, and outcomes were similar to the higher dosage. So this was considered from an equity perspective to potentially treat more children because of the potentially lower dosage given to children. So the decision to reduce RUTF quantity for children who are no longer SAM should be made at program level, taking into account factors like food security and others. Okay, also very important for Indonesia's context, the management by community health workers, which we have a strong cadres here, no? So this was a very big shift from the 2013 guidelines, which focused on CHW's screening only and referring children with wasting. For the 2023 guidelines, there was a conditional recommendation that required adequate training and regular supervision of CHWs. And the recommendation has factored in that CHW networks and capacities can be very different from country to country. The evidence from this recommendation came from studies where there were very close supervision and training from NGOs. In the case that it is not possible to implement this recommendation, trained CHWs should still identify and refer infants and children with wasting and or nutritional edema for full assessment at the health facility. So again, the recommendation is conditional that if CHWs have capacity and they are supervised regularly, they can actually provide the service. They can manage children with SAM. However, important in the last point that CHWs should not manage infants less than 6 months. That will still be with the health professionals because they require a different set of skills. We now move on to moderate acute malnutrition or moderate wasting for the same age group. And there was also a very important shift in focus. So we are not treating moderate acute malnutrition or MAM, and we need to shift our language, our policies, and our protocols. We are only supplementing 40% to 60% of the child's dietary needs. And the most sustainable approach is still the use of local or home foods. So all children with MAM is based really on one principle. One principle to understand is that children with MAM are also on a spectrum. And this could be from a child on the margins of being moderately wasted due to a recent illness, or a child falling close to the SAM diagnosis. What is clear is that all of them need access to nutrient-dense home diets from locally available foods. This is a shift from the focus of the dietary management or treatment in the previous 2013 guidance to provide their nutritional needs from home foods. And reflecting that children with MAM are on a spectrum, the caloric requirements to support recovery are also given in a range. So that's 100 to 130 kilocalories per kilogram, which, as you see, is the higher than that of a non-malnourished child who need about just 80. The second statement reinforces also the importance of medical and psychosocial aspects of treatment. It emphasizes that diet alone is usually not sufficient. So all children with MAM need a health assessment, again, coming back to a comprehensive health assessment, to rule out the medical problems that could be the cause or the main driver of MAM. And the same goes for psychosocial assessment. In some cases, and I've seen this also, addressing the medical and psychosocial problems can also address moderate acute malnutrition. The last statement is that this is a prelude also to the rest of the MAM recommendations, which focuses on supplementation with specially formulated foods. The headline statement here is that not all children with MAM need specially formulated foods. These will be more those with risk factors that make them more likely not to recover or die, and it is these children that need to be considered for specially formulated foods, or SFFs. Therefore, we should prioritize specially formulated foods for certain contexts and factors, because these are the children identified to have higher risk of poor outcomes. Providing these specially formulated foods should be done together with other interventions, such as counseling or other foods, and to the extent possible. So some of the individual child factors to consider are listed on the screen. This include a weight for age below -3 Z-score, if a child has not recovered from MAM despite all other interventions, or if they relapse, have comorbidities, or a history of SAM. There are also children with risk factors due to social factors and personal circumstances. And for example, this is when the mother is absent because she is too ill or unfortunately has passed away. In the high-risk context, that's the one to the right, which the guideline spells out as not limited to humanitarian crises, all children with MAM should be considered for specially formulated food. And again, the keywords here would be food insecurity. And these are the contexts where most of the population is affected by the factors listed here, including food insecurity, low socioeconomic status and income, and places where there is a high incidence or prevalence of wasting, which could be seasonal. And the decision on which factors a country or specific program should prioritize should be based on the context and consider feasibility, acceptability, and also equity. When specially formulated foods are needed, lipid-based supplements are the first to be prioritized. These are formulations that adhere to the technical specifications of RUTF or RUSF. That's RUTF, ready-to-use therapeutic food, or ready-to-use supplementary food. which meet the Codex specifications of ready-to-use foods. If these are not available, which is in the case for Indonesia, then fortified blended foods with added sugar, what happened? With added sugar, oil, and or milk will actually be considered improved fortified blended foods, which is better than those without these ingredients. In a systematic review to answer this question, the guidelines also highlighted the conclusion that the lipid-based nutrition supplements were favored in effectiveness on child health outcomes and costs. However, there's a lot of variability of the cost depending on inflation and also transport. So the costs of improved FBFs, depending on the setting, has been considered. The last recommendation is also important, that we need to meet a range of 40 to 60% of the total daily energy requirements from the SFF. And the exact target should be based on contextual factors. Again, there is an indication for supplementation at SFFs. The principle that home diets should meet as much of the nutritional requirements as possible remains. Third subsection, we're nearly there. So this is one of the new areas that WHO really highlighted, no? The post-exit interventions after recovery from wasting. These are the new recommendations with the rationale that children who are recovering from wasting have a high rate of relapse and risk of mortality following nutritional recovery, which warrants greater emphasis on monitoring and also interventions after they exit the treatment. There are three main recommendations for this subset. The first reinforces the importance of, again, a comprehensive approach to post-exit interventions for both the mother and the child. Again, reinforcing the importance of the mother and child diet in the first 1,000 days. The next recommendations are about the type of interventions that have been found to reduce the relapse rate or prevent relapse. And these were narrowed down to counseling and education, support to responsive care, so providing the care that's needed by the child depending on the cues or what he or she is communicating. And lastly, safe water, sanitation, and hygiene interventions. Again, so wash, no? Psychosocial stimulation and also cash transfers were also highly emphasized. So psychosocial stimulation should be started during treatment and continued after exit. And this includes responsive feeding and caregiving. Cash transfers are also an option dependent on the feasibility and cost in the context. The last subsection, yay. Prevention. Also very new. This was only launched November of last year. So this is now a comprehensive approach to preventive interventions in contexts where wasting and nutritional edema occur. This is again implemented through a multi-sectoral and multi-system approach, not just for health, but also food, wash, and also social protection systems to ensure that the children and families have access to healthy diets, nutrition, and also medical services, good counseling on IYCF, and also psychosocial elements of care. In areas with high food insecurity, the use of specially formulated foods like MQLNS or SQLNS can be used for limited duration, and we also can prioritize children living in the most vulnerable households. So, what does this all mean for Indonesia? No? We have to make sure that, so these guidelines are recommendations, but it is still up to the country to adopt them and to operationalize depending on what the context is. So this is what I mentioned also before, no? So the technical guidelines is one thing, but how to do it is very much different in a country. So WHO and UNICEF, as I mentioned, is developing also a set of operational guidance as something that a tool that countries, communities can use to do what is needed to do. So we are also looking at a set of guidance for policymakers, guidance for program managers, and guidance for healthcare workers. And these will be launched soon over the next couple of years. Research. And this is something that Professor Anwar mentioned a while ago. No? And I think this is where Unhas also has that capacity to do it. We really have to also make sure that the remaining research gaps, the remaining questions that we have identified within the guidelines is also answered by robust evidence, by your students, and also by professionals. We have to make sure that we identify important aspects of protocol design, and we have to make sure that evidence to decision-making process following the great principles is followed. Dissemination and also, oops, I'm seeing myself. I don't know what happened. Disconnected. The third is dissemination and local adaptation. So we have to make sure that we send and share these guidelines and updates widely as possible. And we have to make sure that similar to what we do, that these technical guidelines are understood by those who need to decide and those who need to design the programs themselves. Thank you. So we have to, similar to what we're doing, I'm working with countries to integrate recommendations and operational guidelines into national health and nutrition policies, protocols, and guidance. Within East Asia and Pacific region, only 3 countries have started really working on this. That's PNG, PG, and also Laos. And I know that Indonesia is also preparing to update the current guidelines. So watch out for that space, and maybe you can also contribute to that process. After adaptation, we also have to make sure that existing tools, including training packages, are also updated. So this doesn't stop here just at the updating of the policies itself. We have to make sure that tools and also training packages are updated. So you are here, the UN partners also, not just UNICEF, WHO is there, FAO, World Food Program, all those who are contributing to the GAP framework are here to support the countries. That's it. Thank you very much for your attention. Thank you.
Okay, thank you very much, Mr. Reina, for the sharing and the materials. I think it's very interesting for me. I think it's very interesting to see. Maybe sometimes we think it's very basic to see the definition, but then it's very important to early detection and also to have prevention and suitable prevention and treatment. So sometimes we think it's basic and then we forget about it, but definition is very, very, very important. Okay, so I think some of you must be have questions for Mr. Rini from his explanation. So please, if you have any question, you can raise your hand and you can ask in Bahasa or in English. If you ask in Bahasa, that's also very, very fine. I will translate for you. Okay, any questions from you? Or maybe from people in the Zoom, you can also ask any questions. You can raise your hand in the Zoom, or you can also type your question in the chat box. Okay. So So maybe while waiting for the participants, I I am I am curious, why should we differentiate the definition between wasting and also acute malnutrition? Like before, we see the difference between wasting and also acute malnutrition. Why it should be different?
Thank you. I was waiting for that question actually. So studies have shown that those with edema are actually more at risk for infections. And there was one case in shown by the health worker in Lapushandu, where a kid had severe edema, bilateral edema, and the skin already had shown dermatoses or infections. So the skin was already inflamed and also losing integrity. So just losing that integrity opens the kid to more infections, more severe infections, and yeah, that just worsened. So there was this move to differentiate between wasting and also acute malnutrition.
Iya, tadi itu bedanya ya. Kenapa sih kita harus membedakan definisi antara wasting dengan malnutrisi akut ya, atau akut malnutrition. Tadi kalau misalnya apa namanya tadi? Sorry, can you repeat the explanation? I cannot explain to them while. Okay.
So it's the nature of the condition itself. So acute malnutrition, the presence of edema is actually placing the child more at risk.
Ya, jadi kalau misalnya ada edema, maka itu akan lebih beresiko bagi anak ya, terutama anak di bawah 5 tahun. Can you elaborate it further? Like I just explained to them that if there is edema, it will be put the children more at risk. But
Yes.
Previously you mentioned about the child.
So this morning we saw a photo of the child where the child had severe edema and also showed the skin was already inflamed and also losing integrity. So that already places the child at more risk because the skin is not protecting the child's legs anymore.
Ya, jadi ada satu kasus di mana ketika anaknya itu sudah edema, maka apa namanya kulitnya juga sudah terinflamasi. Jadi kulitnya itu karena di kakinya itu kulitnya sudah terinflamasi, makanya anak ini menjadi lebih beresiko ya. Jadi bisa kehilangan kemampuan geraknya seperti itu. Jadi itu kenapa tadi dibedakan, kenapa beda sih antara pengertian wasting sama acute malnutrition ya, atau kadang ya acute malnutrition seperti itu. Okay. So for any of you, is there like question, or maybe if you have some experience in the community health services or in hospital, some of them are postgraduate students who already work, some in puskesmas and some also in hospital. Maybe you can share your experiences in handling malnutrition children. Any students would like to share, or maybe would like to ask again, like in what kind of condition where like community health workers like cannot give their treatment to infants under 6 months years old. Like you mentioned, they should have adequate treatment. Like what is adequate treatment means? Like how is adequate? How enough is adequate?
Adequate training.
Yeah, adequate training.
So that's the new recommendation within the WHO. So I wanted to emphasize it again now. So assessment, classification, and treatment of children 6 to 59 months with wasting can be carried out by community health workers, so long as they receive adequate training and regular supervision of their work. And adequate training here is that they should receive a formal training that's provided. That's the standard by the government partners or even an NGO partner, and that there is regular supervision. So there's feedback and mentoring and supervision that's regular, built in as part of their regular work and service delivery.
So they have to have like kind of certification, like they have training. Ya, jadi tadi juga salah satu pesannya ya di rekomendasinya itu adalah untuk bayi di usia di bawah 6 bulan itu tidak boleh di puskesmas gitu ditangani untuk gizi buruknya, tapi harus di pelayanan kesehatan yang lebih tinggi, kecuali kalau apa namanya, kecuali kalau petugas tenaga kesehatannya itu sudah memperoleh training ya atau pelatihan, dan memperoleh pelatihannya itu bukan cuma satu kali tapi secara continuous ya atau berkala, kemudian juga telah mendapatkan supervisi yang ketat oleh apa namanya atasannya seperti itu. Mungkin dari Bulani ada mau menambahkan?
Membedakan dengan pedoman WHO 10 tahun yang lalu adalah dulu itu untuk bayi usia di bawah 6 bulan tidak bisa ditangani di layanan rawat jalan atau puskesmas, harus dirujuk ke rumah sakit. Nah, sekarang ada dua opsi. Mereka bisa ditangani di layanan rawat jalan dengan catatan beberapa syarat-syarat itu ya, yang tadi ada misalnya tanda-tanda bahaya, kemudian beberapa kriteria jika memungkinkan untuk di layanan rawat jalan di puskesmas bisa. Tetapi pada kondisi-kondisi tertentu, ketika tidak bisa diberikan tata laksana di layanan rawat jalan, harus dilakukan di rawat inap. Nah, kapan anak bayi ini bisa ditransfer dari layanan rawat inap ke layanan rawat jalan, kemudian juga frekuensi kunjungannya ketika di layanan rawat jalan itu memang harus dilakukan asesmen yang sangat thoroughly ya, hati-hati, dan memang oleh tim medis yang sudah dilatih dan terlatih. Kemudian mungkin tadi ada satu juga terkait dengan di beberapa negara memang kader, dibilang community health workers, itu bisa melakukan membantu dalam melakukan tata laksana anak gizi buruk di layanan rawat jalan, tapi yang usianya di atas 6 bulan, jadi 6 sampai 59 bulan. Bayi di bawah usia 6 bulan tetap ditangani oleh tenaga kesehatan, tidak oleh kader, atau kita di sini kader ya, tapi di luar biasanya community health workers. Jadi mungkin itu sedikit tambahan dari saya. Makasih Bu Marina.
Terima kasih Bu Lani sudah mengklarifikasi konteks translate dari community health workers-nya tadi itu maksudnya adalah kader ya, bukan tenaga kesehatan gitu ya Bu Lani. Iya. Oke, terima kasih Bu Lani. Oke. Ya, please Ulfa.
Thank you. Actually another student here. Thank you for the change to ask the question. This is actually related to the definition, the question from Bu Marini. So there is a difference between acute malnutrition and wasting itself. But to give you some context, in Indonesia, practically, the health workers supported by community health workers called cadres in Indonesia practically do the screening or the early detection of SAM or mom using the the weight and the height and also the MUAC. And since there is a nutritional idiom in this definition, does it in a way affect the way the cadres or health workers do the screening? Is there any difference between the screening for acute malnutrition and also the wasting itself, because practically they usually do screening using MUAC, weight, and height. Yes. Thank you.
Thank you. Very important operational question also, no? And it's good that because in the ECD center that we visited this morning, they are also teaching the mothers how to check for edema. So that's an important step that we cannot also overemphasize, no? So apart from taking MUAC, taking it, weight and also height and plotting that to get the Z-scores, we also have to check for edema to make sure that we're not missing the presence of edema, bilateral pitting edema in a child. And it's as simple as um, holding the child's feet and pressing using gentle thumb pressure, applying it for 3 seconds and letting go. And if you see an indentation in the skin, similar to when you touch a ripe mango, you see that indentation, no? That's then the presence of bilateral pitting edema. So it's very easy to check, and it's an important step that we should not also miss when we are screening for children.
Oke ya, jadi tadi dijelaskan bagaimana sih kita melakukan edema. Tadi kan sudah banyak ya dijelaskan tentang edema ya, bahwa kalau misalnya harus dibilang kapan sih dibilang kapan dibilang acute malnutrition adalah ketika ada edema. Nah, bagaimana caranya mendeteksi edema itu? Nah, caranya adalah dengan melakukan pitting edema ya. Jadi ditekan pada kedua kakinya, kemudian dilihat gitu apakah ada bekasnya ya. Nanti itu banyaklah dipelajari, terutama ketika belajar tentang pedoman teknisnya di lapangan, bagaimana kita mendeteksi acute malnutrition seperti itu ya. Oke. I think if we don't have any question anymore, I will wrap up this session. There are several conclusion from this discussion today. So we know now that wasting is still prevalent in Indonesia, and it is very important to see how it to define or how to define wasting, and also acute malnutrition, and how to choose suitable treatment, and also we see how to prevent malnutrition and the importance of comprehensive prevention. And we need to really always remember that nutrition alone is not enough. So we also need a lot of effort, and also multi-sectoral effort. I think that's all for today. Maybe Mr. Ren, you have words for keywords for the students here.
Keywords, I've spoken a lot already.
Yeah, maybe one sentence.
Yes. Maybe just as you look into your careers, it's important to also look not just within your sector, but beyond. Consider nutrition, consider research, and let's all work together for the improvement of all children with wasting, and prevent that from happening again within Indonesia.
Okay, thank you
Thank
very
you.
much. Thank you very much, Mr. Rene. A round of applause for. Before we really end this session, maybe we could have like photo session first. Please go here to have a picture together. Thank you.
All right, everyone, distinguished guests, that concludes our guest lecture for today. And we would like to extend our gratitude to Mr. Rain for the very informative and beneficial presentation, and to the Vice Dean, Faculty of Public Health at U.S. Hasanuddin University, representatives from ICONS, and all the attendees for today's active participation. Please giving applause to us. And we hope that has been shared today will enhance our knowledge and contribute to significantly to the efforts in preventing and managing wasting in Indonesia. So I apologize for any mistakes or shortcomings in hosting this event. Thank you very much for attention and participation. Good afternoon and see you in the next time. Thank you.